Hi, my name is Javier, and I will be talking to you about the drug Meperidine, or more commonly known through its brand name, Demerol. Meperidine is the first wholly synthetic opioid drug, having been synthesized in 1939 Nazi Germany by chemist Otto Esleb. Meperidine can be produced in a two-step synthesis. The first step is the reaction of benzyl cyanide and chloromethane in the presence of sodium amide to form a piperidine ring. Then the nitrile is converted into an ester, the result being meperidine. Despite the origin of this drug, it has no sinister effects. In fact, it was created as a potential anticholinergic. An anticholinergic is a substance that blocks the neurotransmitter acetylcholine in the central and peripheral nervous system, and is used to treat involuntary muscle movements. Meperidine's anticholinergic effects were demonstrated in vivo. However, the effects on the biliary and renal tracts have not. Studies have also clearly demonstrated that meperidine is no more effective in treating biliary or renal tract spasms than comparative mu opioids. It was later discovered to have analgesic effects and is now used for the treatment of moderate to severe pain. It is now classified as a Schedule II drug and can be delivered as a hydrochloride salt in tablets, as a syrup, or by intramuscular and intravenous injection. The adverse effects of meperidine administration are the same as other opioids: nausea, vomiting, dizziness, and constipation. Overdose can cause respiratory depression, hypotension, and even a coma. In severe overdosage, particularly by intravenous injections, apnea, circulatory collapse, cardiac arrest, and death may occur. For much of the 20th century, meperidine was the drug of choice among physicians. 8 years after it had been first synthesized, it was released for clinical use. At that time, morphine, whose spectrum of adverse effects were well known, was the only other opioid available. The hope was that this new opioid would offer substantial advantages over morphine and perhaps even replace it. This initial enthusiasm for meperidine was fueled by early studies that reported to demonstrate that compared to morphine, meperidine possessed superior analgesia and less adverse effects. Despite the fact that most of these claims were refuted almost as quickly as they appeared, the myth surrounding the enhanced clinical efficiency of meperidine persisted throughout the 20th century. However, it was later discovered that meperidine was even more dangerous than morphine and other opioids because of its toxic metabolite normeperidine, which will be discussed later. As a result, the use of meperidine as a pain treatment has declined heavily in the United States, with many hospitals eliminating its use in emergency departments. But it is still commonly used in the UK and New Zealand, with the former using it as a treatment for pain during labor. This is probably due to meperidine providing more reliable analgesia as the first stage of labor progresses, as compared to fentanyl or sufentanil. To go into how meperidine is much more dangerous than other opioids, we first must understand how the drug acts inside the body. Like most opioids, like morphine, it is a mu-opioid receptor agonist. However, meperidine is more lipid-soluble than morphine, resulting in a faster onset, which is around 120 to 150 minutes, and has a half-life of 3 to 7 hours. This faster onset causes a higher chance of dependence or addiction, since there is a stronger association between taking the drug and feeling the euphoric effects. When meperidine is taken, it is quickly hydrolyzed in the liver to make pyridic acid, and then demethylated to the toxic normeperidine. Normeperidine has a half-life of 15 to 20 hours. Because of this, if meperidine is administered on a scheduled basis, normeperidine can accumulate. Normeperidine is extracted renally, which puts patients with renal failure at higher risks. The unique adverse effects of meperidine caused by normeperidine include serotonin syndrome, seizures, delirium, and tremors. Serotonin syndrome is caused when there is excess serotonin in the brain. Symptoms include confusion, agitation or restlessness, dilated pupils, rapid heart rate, muscle twitching, and heavy sweating. Severe cases can be life-threatening and cause the following symptoms: high fever, seizures, and irregular heartbeat. The toxic effects caused by normeperidine cannot be controlled with opioid receptor antagonists such as naloxone or naltrexone. However, the neurotoxicity caused by normeperidine may be treated with hemodialysis. An issue that has arisen because of meperidine is the discovery of MPTP, a compound accidentally produced when manufacturing MPPP, an analog of meperidine. By itself, it's not toxic, but when in the brain, it is metabolized to MPP+, which then kills primarily dopamine-producing neurons in the pars compacta. This toxic effect can result in Parkinson's-like symptoms. However, the exact mechanisms by which MPP+ does this has not yet been established definitively. Because MPTP itself is not directly harmful, toxic effects of acute MPTP poisoning can be mitigated by the administration of monoamide oxidase inhibitors, or MAOIs. MAOIs prevent the metabolism of MPTP to MPP+ by inhibiting the actions of MAOB, the enzyme that metabolizes MPTP, minimizing toxicity and preventing neural death. The discovery of MPTP has not been all bad though. The discovery of this toxin has stimulated new research on environmental factors that might contribute to this progressive degenerative disorder and provides a means for asserting new approaches to therapy. Thank you, and I hope this video has given you a better understanding and insight into the drug meperidine.